Good evening, Dr. Sri Puspitasari.
Good evening.
Okay, how are you doing?
Thank you. I'm fine. How about you?
Yeah,
I'm very honored to join the meeting.
Thank you for your participation. You will run your slides by yourself, or the host will run for you. It's up to you.
My presentation by myself. Thank
Okay.
you.
Okay, thanks. Good evening, Professor Yik-Hong. Are you online already? Professor Ho. Good evening, Professor Puruhito. Professor Puruhito, are you online? Good evening, Professor Paul Tahalele.
I'm online.
Oh, okay. Thanks, Professor. Good evening, Professor Sri Mariwan.
Good evening. I'm
Hi.
online.
How are you doing?
Fine, thank you. And you?
Thanks. I'm fine too. Good evening, Dr. Frans.
Good evening, Dr. Peter.
Yeah.
How are you?
Fine, thank you.
Okay.
So you will deliver your presentation with slides, Dr. Frans, or just
Yes.
okay,
It will
okay.
be about 5 minutes presentation with slides.
You will run your slides by yourself, or the host will
I
do it
will
for you?
run the slide myself.
Okay.
Thank you.
Okay. Thanks. Good afternoon, Professor Tsoulfas. Professor Tsoulfas, are you online? We will get started about 5 minutes.
Is there Professor Yik-Hong who is there?
Uh,
Not yet.
I don't see his name in the list, but maybe later on. Yeah, we will wait about 5 minutes, and then
No,
we
but
will.
Professor Puruhito is there.
It's already Professor Puruhito, but he's still in his
Come
clinic.
later on.
Yeah, later because he's in his clinic,
Oh yeah,
and
okay, good.
we'll join later. About yeah.
Yeah. Professor Tsoulfas is there. Hello.
Good afternoon, Professor Tsoulfas. Are you online? Professor Tsoulfas, are you online?
Lama-lama orang kan bosan terus-terus gini. Gitu. Selamat malam, Profito.
Oh, selamat malam, Paul.
Ya, apa kabar?
Oh, pakai masker di mana itu?
Sedang kerja ini. Besok
Kerja di
pagi
mana?
ada wisuda ini. 1000 mahasiswa ya.
Jam
Wisuda.
segini kerja ini bukan pegawai negeri sipil ini berarti.
Ya, swasta kan, Mas. Swasta, Mas.
Oh, Peter, how are you?
Yeah, I'm just fine. Thanks for attending this session, Prof. Puruhito.
Thank you.
I think you are still in your clinic.
No,
Already
no,
finished?
there is no patient. Just
Okay.
1, 2, 3.
We will get started in 3 minutes.
Pak Lunardi, Hendra Lunardi, apa kabar?
Baik, Prof.
Saya kirim pasien kemarin.
Saya lihat Prof Aryawan di sana. Prof
Ya, Prof
Aryawan.
Mariwan. Selamat malam, Prof Mariwan.
Prof Paul ini Prof. How are you, Prof?
Hai, selamat malam, Prof Paul, Prof
Luar
Puruhito,
biasa,
selamat malam.
Prof. Sudah
Apa kabar?
lama tidak
Sehat?
ketemu ini. Sehat-sehat, Prof.
Ya, sehat-sehat.
Sekarang sudah 90 tahun ya.
Ya.
Sama dengan Prof Samsu ya. Prof Samsu 89.
Oh,
Oh, mesti di on kan itu, Prof. Unmute. Nggak kedengaran, Prof.
Selamat malam, Prof Paul. Selamat malam, Prof Ito.
Malam, Pak Lunardi.
Oh, selamat malam.
Saya baru 85 Prof Maramis itu yang 90 Prof Samsu.
Ya, betul. Prof Aryawan, Prof Marami 94. Prof Samsu tadi malam masih chatting dengan saya 89.
Wah, hebat ya.
Iya, luar biasa. Jadi
Prof
teladan
Paul
juga.
sehat ya?
Tamu kita dari luar sudah join ya, Bet?
Tadi ada email dari Profesor Yik-Hong, itu dia tadi dia coba kok tidak bisa nyambung katanya. Saya sudah kirim lagi linknya. Tapi Profesor Tsoulfas bilang dia mau join. Mungkin sudah ada. Good afternoon, Profesor Tsoulfas. Are you online? Profesor Tsoulfas? Okay, I think we can get started while waiting for the other colleagues. Good morning, good afternoon, and good evening, everyone. Welcome to the 8th chapter surgical forum of the International College of Surgeons Indonesia section. My name is Dr. Peter Johannes Manopo, General Surgeon. I am the coordinator of this surgical forum, and I will be your moderator in this session. First of all, I would like to express my gratitude on behalf of the ICS Indonesia section to our distinguished guest speakers, Professor Yik-Hong from ICS Australia section, Dr. Sri Puspitasari, Anesthesiologist from Indonesia, and Professor Puruhito, cardiothoracic surgeon from ICS Indonesia, and also for the World President of ICS, Professor Tsoulfas, and Professor Paul Tahalele, the President of Indonesia section, Professor Sri Mariwan, the elect President of Indonesia section, Dr. Franz Arifin, the Secretary of the Indonesia section, and Professor Andi Asadul Islam, the Vice President of the Indonesia section, and all the participants of the sessions. Now we come to the opening session, and for the first opportunity, I would like to invite Professor Paul Tahalele to deliver the opening speech. Professor Paul Tahalele, time is yours.
Thank you, Pat. As a moderator, good days for everybody. Greeting from ICS Indonesian section. Friends from all over the world, ICS members are still healthy and happy even though during the COVID-19 pandemic. Thank you very much for our honorable speakers, Professor Yik-Hong. He is a colorectal surgeon from ICS Australia section, and Professor Yik is my best friend.
He is a past president of ICS Global. And the other speaker, Professor Puruhito, is my senior, my teacher. Thank you, Prof Puruhito, from ICS Indonesia section. He is a cardiothoracic and vascular surgeon. And Dr. Puspitasari, also my friend, my colleague in the team of cardiac surgery in Dr. Storm Hospital. Thank you, Dr. Puspitasari. And welcome, Professor Georgios Tsoulfas, our President of ICS Global. How are you, Professor Tsoulfas? Are you well? It's okay. Might be come later on. And Mr. Downham as Director of Executive of ICS Global. Thank you very much for your participation of this international virtual seminar. This is held by ICS Indonesian Section Forum, Chapter 8. I hope all the participants will happy and get knowledge and experience from the speakers. And thank you very much once again. Have a nice seminar.
Thank you, Professor Paul, for your speech. And for the next opportunity, I would like to invite Professor Tsoulfas. Professor Tsoulfas, are you already online?
Yes, I'm already online.
Yeah. How are you doing, Professor Tsoulfas?
Good.
Yeah, the time
Thank
is
you.
yours. Yeah.
Thank you very much for the invitation. It's really a privilege and an honor to be here amongst you. And I want to take this opportunity to congratulate Professor Manopo in the Indonesian section for creating a tradition with his webinars. This is really an example for all ICS national sections, for the ICS and for any surgical association to follow, having this regularly planned international really webinar rounds. This, you have taken a difficult situation and created an opportunity out of it, and I think it's something that all the fellows can benefit from, and I think we're all going to be wiser at the end of this webinar. So I really want to congratulate you, and it's great to see the participation that's involved. I think this is a tradition and an example, as I said. Congratulations, Peter.
Thank you, Professor Tsoulfas. For the next opportunity, I would like to invite Mr. Max Downham, but I'm afraid that by some health reason, he cannot join this session. So I will skip, and I would like to invite the Vice President, the President-elect of the ICS Indonesia section, Professor Sri Mariwan, to deliver your scientific notes. Professor Sri Mariwan, the floor is yours.
Thank you, Dr. Peter Manopo. I appreciate for your coordination about what we say regularly Indonesian sections forum. Now, and from chapter 1 until chapter 8, it regularly done already. I appreciate you very much. Thank you, everybody. Thank you for your participation, and especially for our distinguished speaker or overseas speaker, Professor Yik-Hong. Good evening. And all of our senior, especially also Professor Puruhito, and all three speakers. Thank you very much for share your knowledge to enhance our what we say, our scientific horizon. Thank you for everybody. I hope this International College of Surgeon Indonesian Section Forum, it will run every month regularly. And again, I appreciate the coordinator of this webinar. Thank you, thank you, Dr. Peter Manapo. Thank you very much for everybody.
Thank you, Professor Mariwan. Excuse me, Professor Tsoulfas. Did I interrupt your speech? Because I didn't hear any voice from you. Or is that by the unstable internet connection? Or would you like to?
Yes.
Yeah, you can.
Yes, no.
Yeah, you can progress again.
Okay. Well, no, you didn't interrupt. All I said was that this is really a great opportunity to have everybody together, and in a difficult situation where we cannot have the meetings, where we cannot see each other, using these webinars, you're able to provide the educational element to surgeons, not just in Indonesia, but all around the world. And also by having surgeons from all around the world participate, I think there are certain advantages to using this technology. For example, someone that might not have the time for international travel, they can participate and give a lecture in this great event. And I think what's even more important, it makes it more accessible to the younger generation of surgeons who are the ones most likely to benefit from this. And so congratulations on creating a tradition here, and something that will stay with us for a long, long time. This Indonesian chapter is being a leader in the ICS with these educational events. Thank you very much.
Thank you very much, Professor Tsoulfas, for your speech. And for the next, I would like to invite Dr. Franz Arifin to deliver the business issues of the section. Dr. Franz, the time is yours. Dr. Franz, please unmute your microphone.
Sorry, I'm sorry.
Yeah.
Thank you,
Okay.
Dr. Peter.
Yes.
Allow me on the business session to present a short history of the International College of Surgeons. Because of the limitation of time, it will be distributed in a few parts. I will present the founding years, or part one, today. This is as the information for the members of the International College of Surgeons, because as we know that the history of an organization is what makes the organization in the future. The International College of Surgeons is were founded in Geneva at the December 28th of 1935, and it is now this December will be 85 years old. In 1936, it is the year of the founding of the US section. So this is the section that is first founded after the international organization. And in 1938, the first journal, which is not international surgery at the time, the name is the Transactions of the ICS, Journal of the Transactions of the ICS. In 1938, we performed the first international assembly, which includes 39 US states and 6 countries. And in 1939, the second international assembly is done at New York. Our founder is Dr. Max Torex, And this is his vision of the International College of Surgeons. He said that we must share experiences, discoveries, and all research for the sake of science. And many eminent men in surgery have declared that the common language of scientific endeavor and the interchange of experience enrich the surgeon. When in a mutual evaluation with fraternal obligations, there is a sharing of experience and a mutual participation of advancement. The vision of Max Thorax is a global organization which connects all of the surgeons in the world, and the ability to share experience, discoveries, and research. One of the first executive committee of the ICS is Professor Rudolf Nissen. As we know, in the surgery, we are familiar with the Nissen funduplication. It is named after him. He said that in the meeting of the first assembly, the International College of Surgeons is specifically interested in furthering the standards of the average practicing surgeons, the unknown soldiers of surgery, who is still the most important person in the practice of surgery the world over. This is another point of the International College of Surgeons, which is we do not discriminate whether the surgeon is top-notch or whether they are practicing in the academic hospital or in any hospital, because the role of surgeons in the world is just the same for everyone. They have their own contribution to the practice of surgery. In December 28, this is the one of the documents. It is an interesting document because it is the first page of minutes of General Assembly of the founding of the ICS. The founding committee includes 3 members, which is the president, Professor Albert Jenser, the secretary, Mr. Pierre Jandin, he is a lawyer, and the member is Mr. Emil Adler. The first president is not Mr. Max Thorax, Dr. Max Thorax. The first president is from Prague, which is Professor Arnold Jirasek. The first vice president is Dr. Rudolf Nissen from Turkey, and Dr. Max Thorax acts as the general secretary, and Dr. Albert Jenser from Geneva is the secretary and treasurer of the Europe section. One of the motto of the International College of Surgeons is Pro Omni Humanitate, it's in Latin, which means for all humankind. This motto is presented by Dr. Andre Crotty from the United States of America, the second ICS president. He mentioned in the meeting that the science has no country because knowledge is the patrimony of humankind, the torch that illuminates the world. So we do not discriminate whether by race, by religion, or by country, the advancement of humankind. This is the development of the International College of Surgeons up to 1950. The first one is United States section, and Canada joined in 1950. The first, the early journals of the ICS, which is the transaction of ICS journal, is have 5 distinguished editors. One is the Max Thorax himself and Rudolf Nissen, but another distinguished member is Hamilton Bailey, which we are familiar with the textbook on trauma. He is one of the earliest trauma surgeons in the world. Now, the International College of Surgeons is a member of the Global Alliance for Surgical, Obstetric, Trauma, and Anesthesia Care, which it is one of the collaborators of the WHO for the GIEEC, which is the G4 Alliance. That is why that the membership of the International College of Surgeons also includes not only surgeons, but OBGYN, anesthetists, and other related fields to the surgery. I think that will be all that I can present today. The next part will be on the next meeting. Thank you very much, Dr. Peter.
Thank you very much, Frans, for your history and foundation of ICS presentation. And now we come to the scientific session. For the first opportunity, I would like to invite Dr. Sri Puspitasari, anesthesiologist from Indonesia, with the topic on anesthetic procedures in cardiac trauma. Dr. Sri Puspitasari, the time is yours. Please unmute your microphone, Dr. Puspitasari, because we cannot hear your voice. Dr. Puspitasari, please unmute your microphone.
Okay, sorry, I'm sorry. Thank you for the opportunity given to me at the first time. Actually, I kind of surprised that the first time is my time, but thank you for that. Is it my presentation there?
Yeah, your slides is clear, your voice is clear. Kindly progress.
Okay, thank you for the opportunity. So we will have to discuss this anesthesia procedure in cardiac injury. This case is very challenging because it's not easy to identify the cardiac injury. Epidemiology, men in their third and fourth decade are the most often affected with the cardiac injury, both in blunt and penetrating injury. While pediatric patients will get injured with blunt cardiac injury within their age of 7, and mostly they get it from the motor vehicle accident. Cardiac injury by type are divided into blunt and penetrated, as I revealed before. And by site, it can affect the cardiac structure and great vessel, from myocardial, atrioventricular valve, pericard, and coronary vessel injury. And cardiac lesion, you can see the anatomy of the cardiac. If it hit atrioventricular valve, then acute valve insufficiency could happen to the patient and also make the consequence of anesthesia problem. Septal rupture in the ventricular or atrium defect can happen. And also myocardial, if it hit myocardial, then ischemic heart or rupture heart could also happen. Pericard injury could make the patient falls into the tamponade cardiac, and it's life-threatening. Herniation of the cardiac, strangulation, or epicardiac artery compression that make the heart ischemic. It's also coronary vessel injury that leads to bleeds and ischemia of the heart. Because of the anatomical, the right ventricular is the most often part of the heart that hit, and followed by the left ventricle, right atrium, and then the left atrium. And patient with multiple traumatic injury, the damage is extensive, and it might be covered another injury that happened to the patient in the same time. Multiple injury might be needs a multiple surgery, pain, medication, antibiotic. Infection may occur because and possibly organ supports that could lead to the organ transplant. This condition can be undertreated due to difficulty of identifying organ damage after an accident. Especially there also happen hypoxia, hypercarbia, hypertension, and decreased consciousness. Symptoms are hidden by adrenaline and shock, and the only readily apparent sign of trauma is bruising. However, other symptoms may develop over time. Because of that, the anesthesiologists have to be aware in the preoperative, intraoperative, and also postoperative course that symptom may develop over time. This is the key of our management. In cardiac injury minor trauma, we have to obtain the ECG evaluation. And if we find there are new onset of arrhythmia within 3 or 12 hours after the accident, so we have to suspect there are cardiac injury, especially if there is hypotension to the patient. But if we don't find it, we can observe the patient. If we find those signs, then we should do further evaluation and ICU monitoring. So what about the major trauma? In the major trauma, of course, there's a Tsoulfas protocol to be applied. The first time we do is do the primary survey and stabilize the airway, breathing, circulation, and etc. After the primary survey resuscitation done, then we will exit to the secondary survey. Perioperative management in the cardiac injury always comes first in every case is airway problem and aspiration risk and T-spine control. And also we have to ready to get the possibility of unstable hemodynamic because of arrhythmia, low or high blood pressure, acute cardiac lesion, ischemic heart, or depressed myocardial function because of the injury or maybe because of hypertension and maybe the drugs. Abnormal body temperature, most patients come into the hospital, hypothermia, and it's also lead to the coagulation problems, and oxygen demand will increase with the possibility of decreasing oxygen consumption. So what you have to do? So we have some diagnostic tool. Firstly, history taking, physical examination, ECG, and then laboratory, and also the radio diagnostic examination. The most important thing is there is no gold standard in the cardiac injury. So we have history taking is also difficult because the patient is unconscious, there is no always witness, and physical examination varies from there's no sign, bruises, and maybe there is sign of muffled heart sound, and then increased jugular pressure, and the other signs of another trauma. Troponin is very sensitive, high sensitivity and specificity in cardiac injury, but it's not highly enough in the cardiac injury for diagnosing contusion, myocardial contusion. And chest X-ray plane does not always show the silhouette of cardiac tamponade in early phase of the cardiac injury, even that the volume is quite affected the hemodynamic. OSK fast with sonography, subsurface view is can help us to identify there's a tamponade, pericardial tamponade, and echocardiography will be very useful. And transesophageography has the superiority of transthoracic, especially if the patient have difficulty to position and to get position to get a transthoracic, and it has better view because it's closer to the heart, and it can make difference between volume problem, cardiac problem, or maybe the vascular problem. Perioperatively, intraoperatively, and postoperatively. While in transthoracic, we cannot use it during without stopping the surgery. This is the difference between the TTE, transthoracic echocardiography, and the transesophageal echocardiography. The transesophageal echocardiography, they can reveal more relation better than TTE. So this is show that TTE has a very important role in this cardiac injury management. And if we find out that we have suspected multiple severe trauma with cardiac injury, especially there's hypertension and abnormality of ECG, we should check the troponin level and examine the transesophageal echocardiography. There are problems that we could face in this case, from myocardial contusion, decrease in cardiac function, hypovolemia, hemopericardium, myocardial infarction, or surgical lesions such as valve injury, septal defect, rupture, or trauma of coronary artery. This will affect our decision in anesthesia, because in myocardial contusion, there's increased perioperative risk of mortality and morbidity, a high risk of arrhythmias and hypotension. So we have to ready for the anti-arrhythmia drugs and defibrillator standby. And decrease in cardiac function, we have to be ready with inotropic and vasopressor if needed. Hypovolemia, we have to give fluid meticulously because overload will lead to heart failure, but hypovolemia will make the hypotension more deleterious. Hemopericardium, we can do the pericardiocentesis, but most of the hemopericardium could get clotted and need a surgery. And myocardial infection could get cytocabage, and we have to use the CBB and also the surgical lesion. Maybe we also have to standby ventricle as a device, ECMO, and heart and lung machine. Anesthesia consideration for the case of cardiac injury consists of cardiac lesion-related injury, as we discussed before, meticulous fluid balance, blood loss management. Maybe we need to prepare for the massive transfusion protocol. And then damage control surgery, we have to prepare if the damage is, the damage cannot be taken definitive therapy, and other injuries possibility. As I said that hypotension could be caused by another by others problem other than cardiac injury, maybe by pneumothorax, hematothorax, and also spinal problem, could also, and distribution shock. Other causes of arrhythmia and shock also have to be defined. This is a problem that could occur in the severe trauma involving cardiac injury. So the paramount goal for anesthesia is to maintain stable hemodynamics with every means, like a fluid, and then the right anesthetic agent, and inotropic vasopressor, and also adjuncts such as organ support. In myocardial injury, this is important to avoid ischemia by balancing myocardial oxygen demand and the supply. Delivery oxygen consists of cardiac output and oxygen content, which is cardiac output are affected by heart rate and stroke volume, and the cardiac artery contents affected by hemoglobin and oxygen saturation. Stroke volume also affected by preload, afterload, and contractility. So we have to keep it in balance. Myocardial imbalance could happen because the decrease of oxygen supply or increase of oxygen demand. Oxygen supply decrease because of decreased coronary flow, or decreased oxygen content and availability because of tachycardia, decreased diastolic filling, hypotension, hypocapnia. If hypocapnia happen, the coronary artery will vasoconstrict. Then it could make the ischemic cardiac coronary vasospasm. Oxygen content will less decrease if happen anemia, hypoxemia, and reduce release from hemoglobin. Increased oxygen demand, tachycardia with increased wall tension, especially if there's a aortic regurgitation acute from the cardiac injury, increased preload, increased afterload, increased myocardial contractility, and suffering or fever. In anesthesia, we use intraoperative monitoring. There are basic monitoring as suggested by the ESA, like ECG, pulse oximeter, temperature, and end-tidal CO2, and then cardiovascular monitoring, which is in cardiac injury. This is very important because we have to give the fluid meticulously. We have to prevent the myocardial injury become more deleterious. So we have to, we should put intraarterial blood pressure, so we can monitor it bit by bit, and we can adjust the inotropic and vasopressor dose better, and also we can take the sample for blood if we need it. Also, central venous catheter, TE intraoperative is very important, and also advanced hemodynamic monitoring or cardiac output monitoring will be helpful, but it's not necessarily have to be. Pulmonary artery catheter can monitor the pulmonary artery pressure, especially if there are right heart dysfunction and there are pulmonary artery hypertension. So we can observe the pressure of pulmonary artery and manage if there is rising in the pulmonary artery pressure. The other monitors is like brain monitor, like an EEG. So we can, with the EEG, we can observe the depth of anesthesia. So we can give anesthesia drug with more precisely, and cerebral oximetry to evaluate the oxygen adequacy for the brain, and point of cardiac testing as the thromboelastography, because we in the cardiac injury we have to do the fluid balance meticulously. Blood product also have to be given with very considerate. Thromboelastography we can know, it make us know which problem in the coagulation. Okay. Equipment adjunct in the cardiac injury management is defibrillator, cell saver, intra-aortic blood pressure, ventricular assist device, ECMO, jet infusion, and blanket warmer. This is heart and lung machine, and this is ECMO, and this right side down below, this is pulmonary artery catheter. And this monitor can evaluate the heart rate, oxygen concentration, and methemoglobin saturation, and pulse oximetry index, and platelet variability index to consider fluid responsiveness. And if there's pulmonary hypertension and given nitric oxide, we have to observe the methemoglobin and carbon monoxide saturation. And despite we can know that we can evaluate the BIS AAG, the depth of anesthesia, the depth of muscle relaxant, and the regional saturation of the brain. With the cardiac output monitoring, this one is 51,000. We can find out is there enough delivery oxygen and oxygen consumption in the patient's imbalance, so we can more give the therapy more meticulously. These are the equipment that can that we can use for cardiac output monitoring. This is a TE that we can do it not only with the lateral position but also the supine position, and this thromboelastography. So we know if the patient is in bleeding, we know the problem of the bleeding. This is intra-aortic balloon pump. So for the acute valvular insufficiency, ventricle volume load overload could happen, and pulmonary hypertension, the rising of tensor will lead to the heart failure. So endogenous catecholamine response is inadequate. Inotropic drugs and vasodilator or IABP or more ventricular device, even ECMO, is needed to support the failing circulation. We can use it before and after definitive surgical repair to save the patient. In acute valvular injury, acute valvular insufficiency, the anesthetic goal is to minimizing regurgitant flow, providing adequate systemic perfusion, and maintaining adequate level of anesthesia. So the regurgitation is not get worse. Postoperative management, we also always monitor the continuous ECG for ischemia, prevention of hypoxemia, hypercarbia, hypovolemia, hypertension, and acidosis. We have to give the effective vein management to reduce stress, adverse hemodynamic and hypercoagulable state, adequate HB concentration, venous extubation done smoothly by avoiding sympathetic stimulation. For the aortic injury, cardiorespiratory insufficiency, tissue hypoxia, acidosis are the common presentation of this type of victim. Initial management advanced thermal supply principle should be followed. And we can use the rapid sequence induction with pre-oxygenation as 100% of oxygen. And if there is availability of double lumen endotracheal tube in aorta injury, it will be preferred. Once again, the selection of drugs for intubation is not very important, but the anesthesiologist should evaluate the situation of the patient physiological status and adjust the dose accordingly. Hypovolemia after induction and aorta injury should be promptly controlled with vasopressor and volume replacement to prevent further myocardial injury. And anesthesia goal for often aortic surgery is to reduce the stress in aortic wall, reducing the blood pressure systolic less than 140 using beta blocker or nitroglycerin. Aggressive reduction of blood pressure during aortic cross-clamp with sodium nitroprusside can produce post-operative paraplegia. We can use regional oxygen monitoring to detect. Duration of aortic cross-clamp is the key determinant of the outcome and spinal cord protection in this aortic injury. And mild hypothermia reaching 34 degrees below during cross-clamp can provide benefit, but should rewarm immediately to avoid the coagulopathy. So there is a limited time to do this cross-clamp in aortic injury. Time is out of the essence. Femoral artery to femoral vein bypass. FR2 aortic bypass protect the organs like kidney, spinal cord, brain, and heart. And Lumbardian will help to reduce cerebrospinal fluid pressure and help to increase the perfusion pressure of the spinal cord. This is the monitoring that we use. We have ultrasonography, transvasoral echocardiography, and we have advanced monitoring, cardiac output monitoring, and then we use the ECMO. To remember that working together hand in hand to achieve the same goal. It's very important to have good communication between the team members, especially surgeon and the anesthesiologist. And there is no Superman, but there's only super team. So this is very important. So the take-home message is the anesthesiologist should identify patients with increased risk of perioperative morbidity or an increased risk of mortality. And we have to prepare and anticipate the problem. No particular anesthetic regimen can be advocated as the best choice. There is no single best drugs of anesthesia that could be recommended. The paramount goal of anesthesia is to maintain stable hemodynamic with every means, and teamwork and good communication is the most important thing in the managing cardiac injury patient. Thank you for the opportunity. I hope you all enjoyed my presentation.
Thank you, Dr. Puspitasari, for your very informative presentation. And for the next opportunity, I would like to invite Professor Yik-Hong from Australia section of ICS that will deliver his presentation on the topic of preventing non-technical errors in surgery based on effectiveness of WHO surgical safety checklist. Professor Yik-Hong, are you online? Professor Ho, are you online? Okay, I will skip. Maybe he will attend later on. Now I would like to invite Professor Puruhito to deliver his speech on cardiac trauma. Professor Puruhito, the floor is yours.
Thank you, Peter. Just a minute, I will share my screen.
Yes, sure.
Okay, sorry for waiting. Can you see my slide?
Yeah, the slide is clear. Your voice is clear too.
Okay, thank you. Thank you, everybody. Good evening.
Good evening.
Thank you very much to the ICS chapter Indonesia for giving me the opportunity to speak in this forum. What I like to deliver is a very simple one. It's about the cardiac trauma, and what I will speak is only just for the consumption for general surgeons. Maybe for those who are cardiothoracic surgeons, this kind of cardiac trauma is nothing special. Although Dr. Puspitasari just mentioned about the difficulties and problems in having the anesthesia to deal with cardiac trauma. But if we are talking about cardiac trauma, first of all, we have to recall on the historical background. This is Lexer Rain, the picture of late Lexer Rain is a bold surgeon from Germany who in 1896, it is 124 years ago, for the first time in the history of surgery, has succeeded in suturing the heart. It was happened in Frankfurt at the time, and a man was stabbed on the chest and was delivered to his hospital. And Lexer Rain was very afraid that the man will die. So what he wrote in this publication is that he just, in his doubt, opened the chest and see that the heart was bleeding, and he just put a suture on that heart and sewed it up. So at the time, it was a very astonishing happening. So he mentioned during his speech that from now on, the possibility of performing the suture of the heart should without doubt be taken. Why? Because at the time, although he was pioneering the first heart suture, he was criticized by the teacher, by his teacher, Professor Theodore Billroth, who said that Alexa Rain has violated the ethical. And what he said at the time, surgeon who ever suture a heart or perform to something to the heart will for good lost the respect from his colleague. So it was very cruel at the time. And Beirut said also that suturing the heart at that time was against the ethical thought. But I think for now, those kind of history has been forgotten, and now cardiac surgeon can easily do whatever he wants to the heart, even changing the heart or even making a heart transplantation so far. Okay, what are the facts of cardiac trauma? Number one, uh, if something happens to the heart, it's always a high lethal injury. And gunshot wounds account for 10% of the death before the patient can arrive to the hospital. There is a statistic from South Africa that showed that from almost 2,000 patients, only 6% survived to arrive at the hospital. And with the modern times, although the advancement of the transportation system, still 45% of patients with cardiac trauma can survive if they arrive at the emergency room at the hospital. And until now, this is still remains the number. The blunt cardiac trauma should be less common than penetrating, and the incidence of blunt cardiac trauma is still not known because there are a lot of definitions that I will tell you later on. But in general, the cause of the death is around 25% from cardiac trauma by traffic accident, and just a range of 10 to 70% due to blunt cardiac trauma. And until now, the terms of blunt cardiac trauma is still in confusion because there are a lot of pathogenesis that I will show later on. What can happen if somebody has a blunt cardiac trauma? I will tell you later on. Number one, the penetrating cardiac trauma is the most mechanism of cardiac trauma, and the main causes is gunshot and knife wounds. And generally, the location of the wound is due to point with the entrance of the wound. So mostly, if somebody is being stabbed on the left side of the chest, it will having a penetrating cardiac trauma. The right ventricle or the ventricle of the heart is mostly in the anterior side of the chest, and that's why they are very attractive to have that kind of penetrating injury. From an operation of 711 patients with cardiac trauma, most of the trauma of the penetrating are on the right ventricle, 40% the right ventricle, and less at the left atrium. It's not so much that the penetrating injury can enter the left atrium. And mostly also 1/3 of those trauma are accompanied by trauma of other part of the heart, namely the coronary or septal defect, what Dr. Puspitasari just told you before. If we are talking about penetrating cardiac trauma from the past, it was the war which causes the penetrating. But in the modern time, it's more criminality or social conflict. This is a picture that I got from Professor Paul Tahalele. It was his first experience in treating injury of the heart at that time. This is the classification of heart injury: penetrating, non-penetrating, iatrogenic, and others. I shall translate Indonesia. So you will see that the most important or most lethal effect is the penetrating cardiac injury. What follows after heart is being traumatized? Number one, if there is a foreign body, like a bullet or a gunshot, then it will enter the pericardial space and can cause just disease of the pericardium or having a hemopericardium or the so-called tamponade of the heart. And if there is a foreign body of the subject, which enter the ventricle of the heart, it should be removed as soon as possible. There's no waiting for that. And if it is a bullet which penetrated the myocardium, sometimes it can be stuck between trabecular of the heart, but it can also move freely in the ventricular cavity. If the object is entering the right ventricle, then it can produce through pulmonary circulation the lung emboli or maybe thrombosis of the pulmonary artery. And small object that enters the left ventricle may escape and goes down to the peripheral circulation, or even can go to the cerebral circulation and causes also embolism of the peripheral artery. This is a picture of victim, a boy, which is being shot. Look at here. The entrance of the bullet, which was a rifle gun, is on the right side of his chest. But the X-ray shows that the bullet is now on the left side. And surprisingly, the bullet from the echo shows that the bullet is inside the right chamber. So we did the time in this boy an open heart surgery to take out this bullet. So this is an example. A gunshot wound is sometimes very difficult to detect where the location of the bullet inside the chest, or maybe it could be inside of the heart. How about blunt cardiac trauma? As I told you before, there's a lot of doubt of the definition. Sometimes it is called just a cardiac contusion because it can range just from a simple bruise even until a rupture of the heart and causing tear. It depends on the how big or how strong is the energy that transfer to compress the sternum against the myocardium and pinching it towards the vertebral column. And also, not to forget that if we perform a CPR, or cardiopulmonary resuscitation, it can sometimes also tears on the septum of the heart, even the wall or coronary artery. So be careful if you are doing CPR, which is maybe less for sometimes 20 to 30 minutes. And most of the blunt cardiac trauma accompanied by a sternal fracture. This is a picture how the blunt trauma can happen. Of course, in the nowadays time, all of the vehicles has a what do you call blowing balloon that can protect the heart. But this could also happen. For example, that somebody is struck by a high energy baseball, for example. Sometimes it looked like a hematome in the beginning, but at the end, it could happen a rupture of the myocardial, tear of the muscle popularis, and making a hemopericardium, or lately having a fibrosis or aneurysm. And this diagnosis was having been told you by Dr. Puspitasari. And if there's a bleeding in the pericardium, it is an emergency, and still those various pathology still called the cardiac contusion. That's why the definition of blunt cardiac injury has many range of understanding. How about cardiac rupture? Of course, the greatest risk of death, as I told you before, that only 10% can arrive at the hospital safely. But the biomechanics of the cardiac rupture is this one: sudden increase of the heart cavity, or intra-abdominal pressure, or maybe a deceleration, or just a direct trauma, or contusion of the myocardium, or it could be punctured by the broken rib. And if a patient can arrive at the hospital and still can be resuscitated, mostly the damage are only on the right side of the right atrium. is not dealing with the left ventricle. And most of the victims died before they reached the hospital. And sometimes if there is a damage of the aorta, then it can be more serious, happens that aorta can be ruptured or desiccated, and most of those victims cannot arrive to hospital safely. How about cardiac herniation? Yes, there is a term called herniation of the heart, in which the pericardium is damaged, and there is a hole in the pericardium, there's a tear on the pericardium, and the heart is exit from the pericardial cavity towards the left thoracic cavity. And also sometimes there's also a herniation of the heart towards the abdominal cavity. And of course, this pathogenesis can cause failure of the heart pump because the apex of the heart is pinched by the tear and twisted. And as long as the heart is still twisted, it will cause the hypotension. So if we just change the patient position to the supine position or to lie down, then the blood pressure returns to normal. This is maybe the first measures to have the patient if he or she is having the cardiac herniation. This is a paper from Johan Hoyos, which shows from the lung window that the heart is displaced to the left, and from the abdominal window we can see the empty pericardium. How about iatrogenic cardiac trauma? Yes, it could happen. Number one, sometimes caused by insertion of CPC, or during the cardiac catheterization, or during the endovascular intervention, or even during the doing pericardiocentesis. Sometimes you can also, if you perform the so-called transjugular intrahepatic portocaval shunt, so that means minimal intervention from the abdominal organ can also penetrate the heart. And it will cause so-called failure tamponade. And this can be detected directly by radiologic examination or by the echocardiography. And sometimes also, if we are doing the cardiac catheterization, it can also make a rupture or tear in the coronary artery and result sometimes also in aortic dissection. And again, iatrogenic trauma can be also caused by performing the CPR or cardiac massage. How about electrical cardiac trauma? Yes, sometimes electric shock can cause sudden cardiac arrest, even to myocardial necrosis, heart failure, sudden death, or hypertension. And also, those pathology can be indicated from the abnormalities of the ECG. The electric current can cause direct damage to the contractile heart tissue, or the heat generated by the electric current can also damage the heart muscle. What is the signs of penetrating cardiac trauma? There's a range of cardiac arrest to asymptomatic. So sometimes there's no symptoms. Like the picture I showed you before, the boy with the gun rifle shot, there's no big signs. He didn't show anything. Yeah, he just no pain even because the bullet is small, but we know then that the bullet was inside the heart. So the range is sometimes just if it's a big bullet, of course, the patient will die due to cardiac arrest, but sometimes also asymptomatic. But if it's a stab wound from the knife, then mostly accompanied by tamponade of the pericard. But fortunately, the blood will clot, so sometimes the wound will stop. But if there is a volume over 100 cc in the pericardium, it will show the so-called classic back-rise sign. It's decrease of heart sound, hypotension, with jugular vein distension, and also the presence of pulsus paradox. Although those signs is rarely seen in such clear signs in the clinic. Typically, there's always a narrowing of the pulse pressure. This is a more good sign if there is a penetrating cardiac trauma. This is a picture of a cardiac tamponade. Maybe you have seen this picture many times. There is a cyanotic or pale appearance of the patient, low blood pressure, and the therapy, the measure is try to puncture and take away this tamponade. Of course, you have to give the infusion and transfusion. And if there is a back rise, then the diagnosis of the cardiac trauma is clear. If there is a blunt cardiac trauma, the signs is also ranging from various clinical symptoms. It may deposit just a dysrhythmia, mostly premature atrial contraction or premature ventricular contraction. The mechanism is unknown. But mostly there is ventricular tachycardia, or even sometimes to fibrillation until the tachyarrhythmia. And it can be seen during late hours, maybe 1 day to 2 days after the trauma. So that's why the definition of cardiac trauma or cardiac contusion raises doubt in its management, because maybe it should call blunt cardiac trauma accompanied by something by symptoms, for example. It is not easy just to define just simple blunt cardiac trauma. It should be mentioned what is accompanying this trauma. There's an example about blunt trauma non-penetrating, because it will cause what Dr. Puspitasari just told you, rupture of the heart valve, subvalvular apparatus, maybe late necrosis, fibrosis, and aneurysm. So the blunt cardiac trauma should be observed for a longer time. How about the trauma just to the pericardium? Yes, it is rare. Just pericardium or pericardial trauma is rare, but mostly those patients with cardiac care are unable to get the hospital because of other accompanying trauma. And it shows the mortality could be RS to 65%. Also, it would show the sign of heart herniation, and also can sometimes resemble the symptoms of pericardial tamponade. And again, if there is a hypotension to the position of the heart, just change the position if there is a suspicion of herniation of the heart. If the patient is placed in supine, the blood pressure is better, then it will show the diagnosis of pericardial herniation. But further, those pericardial rupture can deeper became rupture of the myocardial, and in which there's a massive bleeding even until death. So in general, the management of the trauma, number one, in extreme circumstances, you should perform a direct thoracotomy. So if the patient can arrive to the hospital, it will maybe cause something that it still can be helped, but otherwise they don't or they cannot arrive to the hospital. If there is a severe hypotension, then you should immediately do the pericardial window. And after those emergency thoracotomy, you remember the history as Dr. Rain just showed suture the heart, the time there is no anesthesia at the time, there is no antibiotic. I think in the time penicillin was not yet found, but maybe the patient just having a rupture or small rupture in the ventricle. So it is simple, just suture out or sew up the rupture. But if the trauma is deeper or bigger, then it can happen a lot of pathology. This is the emergency thoracotomy that you can carry out from the fourth intercostal space anterior directly to the heart. You just can have this direct suture with control of your finger at the time, or helping with the successive forceps and suture it up. It's a very simple suture to do that. I think general surgeon can do that if you are able to do that, or you just put, this is a good example, put the Foley catheter, yes, Foley catheter from the bladder, blow it up, and then just pull it out and stop the bleeding. And if there is an involvement in the near of coronary artery, try to put the suture like this, temporary. Yeah. If you are doing a laparotomy, you can also inspect the heart through this kind of approach, whereby you just take with two forceps the diaphragm underneath of the heart and open the diaphragm and then open the pericardium. There is also so-called complicated cardiac trauma. That means that accompanied by injury of other apparatus of the heart or other part of the heart, including the coronary artery, heart valve, annulus, papillary muscle, chorda, even producing the so-called intracardiac fistula or septal defect. Trauma for the coronary artery is rare, but the mortality is big. It's almost 70% mortality if coronary artery is damaged or is traumatized. Even we can control with later CABG if the patient still alive, but it's still having a high mortality. Trauma to the valve operation is also very rare because it must be a very deep or maybe a very powerful blunt trauma. And this blunt trauma again can produce a very big damage to the heart. And also fistulas or defect of the septum is also rare, incident of just around 2%. And the management depends on the symptoms. Partly was being told by Dr. Puspitasari, but this management is dealing with a specialty in the cardiothoracic surgery. So I will not tell you a lot of this time. Sometimes it could happen the so-called late cardiac tamponade. That means late if it is detected more than 1 hour after cardiac trauma. This is an example how you can suture the heart to the ventricle. Yeah, try to put the suture using pledges, or if you don't have pledges, you can use piece of muscle or fascia. Most important is just close the heart as soon as possible, like this with using pledges, Teflon pledges. If you don't have the Teflon, again you can use piece of fascia or muscle. You put this also, as I told before, with Foley catheter, pull it out, and then the wound will stop, and then you just sew the heart with a normal suture through a thoracotomy. Last but not least, we have also sometimes to do the so-called pericardiocentesis. That means we are making a hole, a window of the pericardium. That's why it is called sometimes pericardial window. It's like I told you before, if there is a cardiac component with a trias of back, you should puncture it and drain it out as a diagnostic procedure as well as a therapeutic measure to help the patient suffering from the cardiac tamponade. The point is this, the so-called Larry point, left side of sulfoid, directly to the mid-critical point, and just try to puncture the tamponade or the perigram which contains the blood. So if it is not succeeded, then we made a so-called pericardial window. That means we have to open the pericardium from this approach, a curved incision, or mostly a transfer incision under the xiphoid. And then from there on, you can also approach from the left side thoracotomy, but it is more difficult. And then put the spreader, and the pericardium is open, and please try to make a big wide incision of the pericardium, excise the pericardium, so a window will produce and the content of the pericardial sac will come out. So that's what I like to tell you, to share with you. If there is any question, I will surely happy to answer. Thank you very much.
Thank you very much, Professor Puruhito, for your great presentation. And for the next opportunity, I would like to invite Professor Yik-Hong. Are you already online, Professor Hu? Professor Hu, are you online? Okay, I will skip. Maybe later on he will join us. And now we come to the discussion session. This consists of two parts. The first is the expert discussion. So this is the discussion between the two speakers, so they can ask questions each other. For the first opportunity, I would like to give the turn for Dr. Puspitasari. Would you like to address question to Professor Puruhito? You can proceed. Dr. Puspitasari?
Yes.
Yes.
Yes, thank you for the opportunity. Professor Puruhito, if you don't mind, I would like to ask a question. So, is it better to do the emergency thoracotomy, or perhaps doing it in the operating theater? Thank you, Professor.
Yes, it is a simple answer. Sometimes those patients cannot arrive at the hospital. So if they can arrive at the hospital safely, although with hypotension, we can resuscitate. So there is no need for a real emergency. So you can do it better in the operating theater, but do it ASAP, as soon as possible. So resuscitate the patient and go up to the operating room and open. But in a very high emergency where the patient shows a severe tamponade or bleeding, like what Dr. Rain has done 100 years ago, just open the chest and see what happens. If it is penetrating due to step injury of the knife of the chest, due to a knife, or even sometimes penetration of the rib, you should immediately close or suture the heart first. So you have to do it in a very emergency situation in the ER. So yes, it is advisable to do the ER, but after you have helped the patient and stopped the bleeding, you should come over to the operating theater and do the elective or surgery with special preparation. And of course, the anesthesia is important. I just wonder what happens that time with Dr. Rain in that 19th century. As he opened the chest, there is no anesthesia. And this has also happened to me in my past experience, that I sometimes has to open the chest without waiting the anesthesiologist to do a good anesthesia. Important is to put some IV line and then resuscitate, and then as soon as possible see what happens if there is a real emergency. But again, it depends on the situation. But to make a good precaution is that you must be very careful if the trauma is a blunt trauma. It's more dangerous, although it is less than cardiac. The blunt trauma is sometimes has a dangerous because we cannot see what could happen after the trauma. Yeah, maybe late after 1 or 2 hours, there is a pericardial tamponade, or then a rupture of the valve. That's the importance of the diagnostic. If it's deal with sharp or penetrating, it is easier. If the patient is good, can arrive to the hospital, so the penetration is not that far deeper. Yeah, maybe just on the right ventricle or right ventricle. But if it is deep enough, the knife step wound is deep enough, then the patient will not survive. That's the general condition. So that's maybe clear up what is your questioning. Is okay?
Yeah, thank you, Professor Puruhito. Dr. Puspitasari, is your question replied, or you will ask more details?
Okay, thank you for the answer, Professor Puruhito. And also, I hope that anesthesia is here to help the surgeon to make every operation is with a better outcome. Thank you.
Thank you, Dr. Puspitasari. Professor Puruhito, now it's your turn to ask question to Dr. Puspitasari. The time is yours.
Yeah. I saw in your presentation that you also mentioned about the IEBP and ECMO and so on. I
Yes,
think
Professor.
those measures are dealing if we are doing a real cardiac surgery. Is it true that shouldn't need those devices which is rare to us? Even the heart lung machine is not available in every hospital. But I just like to see if it is just a simple trauma, and like example what Dr. Rain in the past happened to him, and the surgeon is a general surgeon. What kind of anesthesia will you deliver to this patient to help the surgeon to open the chest and try to suture the heart? Will you just having a normal anesthesia, a normal medication, or it must be a special anesthesiologist with a special knowledge in cardiorespiratory anesthesia?
Okay.
Sorry.
Thank you. Thank you for the question. So for the adjunct equipment, of course, that it be addressed for the tertiary hospital in the like a Stom hospital in Surabaya. But of course, and there's emergency, we don't need to use those equipment, but everybody can do the emergency. First thing is life saving, especially to stabilize the patient for further definitive repair. But in some journals, there were ECMO use, especially for the patient that come to the hospital with near arrest, so it can give the time for the team to prepare for the surgery better and to keep the patient in the good hemodynamic status. Perhaps that would be my answer, Professor.
Yeah, you will prefer to do the one lung anesthesia if it deals with opening chest, the left chest, or the normal intubation?
So I think it depends on where we work or where the surgery is. If the double tube DLT is not always available in every hospital, so we could use ETT. But if we need to collapse the left lung, we can use the normal ETT, but we just can advance the ETT slightly to right into bronchial. So the left lung will collapse, Professor. But always better that we can use a double lumen.
So you recommend to do the one lung anesthesia if you have to open the left chest?
It's not always the answer because it depends on the other condition like patient condition, like hemodynamic and the condition of the lungs. Sometimes in the chest trauma, it's not only one lung have the problem, but both lungs is the problem. In that case, if we collapse one lung while the other lung is also in the bad condition, so the patient will be rapidly deteriorate. So it's not recommends to give one lung anesthesia, Professor.
Okay, thank you.
Yeah, thank you, Professor Puruhito and Dr. Puspitasari. And now I would like to open the discussion for the floor. Is there any question from the floor? You can ask directly. Just unmute your microphone, introduce yourself.
Dr. Peter, can I ask a question?
Sure.
Yeah. To Dr. Ita.
Please.
Yes.
In abdominal surgery, trauma surgery for abdominal bleeding, we have a system or research on hypotensive or low pressure resuscitation, which means we do not try to reach the normal pressure when we have not controlled the bleeding. So is it possible to do the similar thing, or is it done in the cardiac surgery trauma? Do we target it because if we push the heart to pump more and more or in higher pressure, it might just stop beating or something else. But on the other hand, if we don't get enough perfusion to the tissues, then we are damaging. Maybe there's a long-term damage to the organs or other organs. How do you balance this? Because I know that some anesthesia raises pressure. Maybe if you put in emergency surgery, sometimes they use, I don't know, in the district hospital, you still use anesthesia T5, which increases blood pressure. Do you recommend, or what types of anesthesia do you recommend on this condition?
Okay, thank you for the question. This is very interesting. So for the deliberate hypertension, it has a limit of 65 millimeter Hg for the main arterial pressure. But for the cardiac patient, it's not recommended because it will make the heart more ischemic. And one of the exception for the deliberate hypertension is a patient with cardiac problem and the intracranial problem. So I would suggest to keep the pressure about 60 to 90 mean arterial pressure. To keep the coronary perfusion pressure above the 40 because it's very important for the coronary pressure. And for the total intravenous anesthesia, as I explained before, that there is no evidence that one anesthetic agent is more superior than others in technique. It depends on how we give the agent and how we can manage and balance the drug of anesthesia. We have a triangle of anesthesia from sedation and then relaxation and analgesia. But for the ketamine, I just suggest that what you mean is a ketamine for intravenous, then make the blood pressure higher. So actually, we can use ketamine also for the case, but we still we supposed to keep the blood pressure for lower as suggested by the deliberate hypertension, but we have to remember that deliberate hypertension has a limited time suggested is about 30 to 60 minutes, no more than that, because it will also affect the perfusion and the peripheral. Thank you.
Okay. Yes, thank you very much, Dr. Rita. Back to you, Dr. Peter. Yes.
Thank you, Dr. Frans and Dr. Puspitasari. Any other question from the floor? You can ask directly to the speakers. Any question? I have a question to Dr. Puspitasari. According to your own experience in the anesthetic procedures of the cardiac trauma, what was the most difficult problem? Because you said that the paramount goal is to maintain the hemodynamic stable. So, on your experience, which one is the most difficult and how did you fix this problem? Thank you.
Okay, the hardest part in my job is to keep the patient in adequate anesthesia. It means that the patient is not awake, and then he or she properly sedated and under adequate anesthesia. But in the other side, that we know that most of the anesthesia agent, even though ketamine in critical ill patient or the in shock patient, also have the effect of vasodilation. So it needs experience, and then it needs good monitoring devices. Thank you.
Thank you very much, Dr. Puspitasari. Any question from the floor? Professor Ho, are you online? I received an email, a recent email from Professor Ho, and he told me that the connection link is invalid. I don't know where is the mistake, but he cannot join this session by the invalid link. Okay, we can proceed with the discussion. Any question from the floor? I have a question to Professor Puruhito. Professor Puruhito, in the penetrating cardiac trauma, in your experience, to what extent you can make a secondary operation or reopen after the repair? Is it very rare or is it frequent?
No, it's not so frequent. In our experience, you have not so many cases until now. I think Professor Paul has published the time from 18 or 19 cases only, and until now, our collection is not exceeding 30 patients with cardiac trauma. The last one is the one that I show you with the air rifle gun. So that is the only one that we did the open heart surgery, because we know exactly the bullet is inside the ventricle. So we have to take it out. Mostly, the tear or the damage is only dealing with right atrium or just the ventricle. I think there were 2 cases with ventricular septal defect after this trauma, and we can detect it after 2 days with help of echo and signs of murmur on his chest. So at that time, so we have to do the real surgery or the definitive surgery after we have completed the diagnosis. So the answer is we should do definitive surgery if there is an accompanying trauma after the primary wound was sutured and stop the bleeding, and that will last maybe 1 or 2 days after diagnosis is done. We have to avoid a longer period of waiting time, because there is a danger of having a pericarditis or another infection. That may be what I have been experiencing in the past. Again, in the last years, we never receive again the penetrating cardiac injury.
Thank you, Professor Puruhito. Any other question from the floor? Okay, if there is no question, I think.
Can I have one question? I'm interested in the Prof Puruhito's explanation about the approach of opening the pericardial sac or evaluating the the heart from abdominal approach. When in trauma is the indication of doing this, Professor Puruhito?
Sorry, once again, what's the last question?
When do we have an indication to explore the chest? The heart from abdominal trauma if we already do the laparotomy? What is the indication, or in what cases?
Okay, of course, there must be a suspicion of the trauma to the heart if there is a step wound, for example, from the abdominal cavity up to the cranial part. So maybe a step by the long knife or a sword from the abdominal, that the abdominal surgeon should resuscitate the internal bleeding, and then you will see from the abdomen up to the diaphragm, to the cranial part, as the pericardial is having what do you call bluish appearance, and there is of course maybe the hematome, of course, or there is a wound directly coming from the step wound. Then you can open that from that part. Although I don't strongly recommend that the abdominal surgeon should do this suture of the heart, because sometimes it's not easy to put the suture on the inferior face of the heart from abdominal. You still have to do open the chest with the thoraco-abdominal thoracal incision. And my recommendation is, if in that case, just continue your laparotomy incision up to the left side of the heart. Then you will clearly and cut the costa, the ribs, and then you will see clearly the side of the wound of the heart in which you can put the suture on it. But to inspect the tamponades from there, you can open the pericardial from laparotomy, just to help the patient not suffering from cardiac tamponade. That's the first measure that you should do against the cardiac tamponade, is open the pericardium and release the tamponade. That's the meaning of what the picture I showed you before. Okay, Frans?
Yes, thank you, Prof.
Thank you, Professor Puruhito and Dr. Frans. Any other question?
Yes. Hello.
Yeah, please.
Hello. How are you?
Oh, this is who is speaking? Professor who?
Dr. Daniel Kokon, Nigeria.
Oh, okay, from Nigeria. Oh, very far away, from the other side of the globe.
Yes,
Thank you very much for participating. Yeah, you can answer. You can address the question to the speaker, Dr. Daniel from Nigeria.
Yes, I listened to all of the speakers. Very interesting.
Yeah.
Dr. Puspitasari, she did very well. I listened to her. Very interesting. She's doing a good job in Indonesia. while Professor Puruhito, the cardiac surgeon, is doing very well. I listened to his presentation. But one of the questions I want to ask is that what is the size of the suture when you want to suture the heart in cardiac care?
Please, Professor Puruhito.
Yeah. Your question is what kind of suture? You can, of
Yes,
course.
what size? What is the size of the suture?
Yeah. Normally, we take the nylon suture, proline or what kind of that, and the size is 4/0 or 3/0, a traumatic needle, half needle, and as good as possible, try to reach the inside of the ventricle. If you don't have that kind of suture, you can still use the polyglycolic type of suture, but recommended is nylon suture. In the past, in the past, Dr. Rain was using silk suture, as long as I know the history, but we cannot use that again. But important is a non-absorbable. Don't use the absorbable.
Thank you very much.
Yeah.
Thank you so much, Professor Puruhito.
You're welcome, Dr. Daniel.
Thank you very much.
Thank you for the question and the reply, Dr. Daniel and Professor Puruhito. Okay. Any other question from the floor?
Hello.
Yes. Please, you can introduce yourself and ask question.
Good evening.
Yes.
My name is Akram, General Surgeon from Makassar.
Yes.
I would like to ask to Prof Puruhito. From the slide that presented, I acknowledge that there is two ways to relieve cardiac tamponade: pericardiocentesis and pericardial window. I would like to ask what the indication, because I have understanding that pericardiocentesis, we do pericardiocentesis in the emergency setting, emergency room setting, and pericardial window in OR, operating room setting. So how we decide that the patient who get cardiac tamponade, the indication, we do pericardiocentesis or we do the pericardial window?
Yeah. In case of trauma, where the pericardial is issued by blood, there is a cardiac tamponade. You just puncture it and try to take away the blood. If you don't succeed, then you have to open it by surgical measure. That's what I mean. So doing the pericardial opening, what we call it pericardial window, is just in case if the tamponade is late, that means part of the tamponade has a blood clot inside the heart. So you should take away the blood clot. But as long as the content of the tamponade is still fluid, is still blood, you can drain it off. And after you drain it off, you have to open the chest to see what is the real damage from the heart, whereby maybe you have to put a suture on the damaged heart. So the answer, if the setting of pericardial window, what we call window, to open the chest is in emergency setting. Of course, there is a surgical treatment doing the pericardial window in case of pericarditis, effusion of the pericardium, but it's not an emergency setting. The so-called late pericardial tamponade, as I told you before, can be observed after 1 or 2 hours. So it's not a real very late, but at least after you observe the patient and you realize that the patient is not doing well with the hemodynamics, and the echo shows, you can do the echo, of course, shows a pericardial tamponade, then you can try to puncture it first. If it's not succeeded, then you do the opening by surgery. And we call it the so-called pericardial window. So it's different with the measures doing pericardial window for a pericardial effusion or another disease, which is not an emergency setting. So emergency setting is just dealing with those pericardial tamponade if we cannot detect immediately and the symptoms shows after several hours, for example, and we can prove it by doing the echocardiography. So that is what I mean with, but try to do first the puncture from the Lare position. So if you can drain off the content of the pericardial with its blood and the patient hemodynamic is good, then it's okay. You don't need to have the surgical measure doing the pericardial opening. That's what I can share with you. It's okay, Dr. Akram? It's what
Okay, thank you,
answering
bro.
your,
Thank you.
yeah, you're welcome.
Yeah, thank you, Professor Puruhito and Dr. Akram. One question from the floor before I close this session. Okay, I would like to invite my colleague, Dr. Daniel from Nigeria, to deliver presentation in our surgical forum, monthly surgical forum. Just write an email to Mr. Max Downham in the head office in Chicago, and then he will progress the letter to me, and I will arrange for that. So this forum is welcome for all ICS fellows worldwide, including Nigeria. Okay, I will wait for your email. Yeah. You are welcome. You are welcome.
I'm really excited by the invitation.
Okay, thank you. And now we come to the end of the session. So maybe Professor Paul Tahalele have a comment about this topic. Please, Professor Paul Tahalele. Professor Paul Tahalele, please unmute your microphone.
My comment is thank you very much for Professor Puruhito. Very nice lecture, and Dr. Puspitasari as my colleague as an anesthesiologist, that we have working together in the cardiac surgical team, Dr. Storm Hospital, and all the lecture and the instruction to apply it in the surgical cases, especially cardiac trauma. I think this a good guideline and decision to overcome this cardiac injury. This is my comment. Thank you very much.
Thank you, Professor Paul Tahalele. And for the closing remarks, I would like to invite Professor Adi Asadul Islam, the Vice President of the ICS Indonesia section. Professor Andi, the floor is yours. Professor Andi, please unmute your microphone. Hello, Professor
Good
Andi.
evening for the, yeah. It's okay. It's the unmute. Good evening for the good evening for all participants and for audience. And on behalf, I would like to say thanks for the all speakers. Very interesting lectures. Our teacher, Prof Puruhito, also Dr. Puspitasari, and Prof Paul Tahalele. Thank you very much. Especially the most appreciated Dr. Peter as our brother and for arrange this meeting. Very nice. And unfortunately, the last meeting, not now, before the meeting before, I cannot join the meeting because I'm still in hospital due to accident. and right now still using the sling arm sling,
Okay.
but would be better. And again, thank you very much for all participants, also for our audience. Question and answer, and makes us open our mind as a surgeon. Even I am not a general surgeon, I am the neurosurgeon. Again, thank you very much for all. Good night.
Yeah, thank you very much, Professor Andy. Hopefully, you are well and healthy, and I hope that this session also will be very fruitful for all participants. And on behalf of the ICS Indonesia section, I would like to express my gratitude to our speakers, Professor Puruhito, Dr. Sri Puspitasari.
You're welcome.
Yeah, and all the participants, also the president of the ICS, Professor Georgios Tsoulfas. Thank you very much again, because your cooperation, participation, while you are quite busy in your clinic, because now it is 5 o'clock, 5 o'clock in the afternoon. And I hope this event will be very fruitful for every participants, and we will meet at the other forum, the 9th forum in November, with other topic and other speakers worldwide. And also I would like to express my gratitude to the office bearers of the Indonesia section, Professor Paul Tahalele, Professor Mariwan, Dr. Franz Arifin, Professor Andi Asadul Islam, and the IT team of the Indonesia section, Mr. Bimo and Miss Devi. Thank you very much. Hopefully, all of you will stay healthy, and we will meet again in the next forum.
Thank you.
Goodbye.
See you later.
Yeah, see you later.
Thank
Thank
you.
you. Thank you.
Bye, Dr. Ita.
Bye, Dr. Franz. Nice to meet you again.
Later. Okay.
My
Nice to
friends,
meet you.
my college.
Bye,
Okay.
everyone.
See you.
Thank
See
you,
you.
everybody.
Thank you.
Night.
Thank you, everyone.
Bye-bye.
Good night.
Yeah, thank you. Good.
Night.
Dr. Daniel from Nigeria, send our regards to all your colleagues in Nigeria.
Thank you very much. God bless you.
Nigeria.
Yeah.
Bye-bye.
Okay.
Yeah. May I leave?
Thank you.